Perfect. Okay, so good morning, everybody. Thank you for coming to today's Let's Talk About session. For anybody who doesn't know who I am Courtney Simmons, and I am the coordinator of community outreach and engagement here with Seniors NL. And today we have Ted McGregor here to talk about aging in place, home modifications, and adaptive devices. So before we get started, I just have a few quick housekeeping things to go over, and then I will hand it on over to Ted. So, like I said, just a few quick housekeeping items. So first, we ask that everybody mutes your mic just to block any outside noise that might be happening where you are. If you need closed captioning, there should be a button right at the bottom of your screen as well. If you have any questions or comments, you can go ahead and put them in the chat and we'll have some time for discussion at the end of the presentation. And just so everybody is aware, today's session is going to be recorded and it will also be posted to YouTube for anybody who wasn't able to make it to today's session. Okay, and before we get started, I also just want to do a quick land acknowledgement before I hand it on over to Ted. So we respectfully acknowledge that the lands on which we live, work, and meet are situated on the traditional territories of the Indigenous groups of Newfoundland and Labrador. And we acknowledge with respect the diverse histories and cultures of the Beothuk, Mi'kmaq, Innu, and Inuit of this province. We honor the diverse Indigenous peoples who have cared for this land for past generations and for the 7 generations to come. We are committed to listening, learning, and working in collaboration with Indigenous communities as we move towards reconciliation, respect, and mutual understanding. Let us carry this acknowledgement forward in our work and relationships as we strive to create a future that respects and embraces the wisdom of older adults and the diversity of all communities. So a little bit about Ted as well before we go ahead and get started. So Ted is an occupational therapist who works with a family care team in central Newfoundland. An occupational therapist serves as part of an interdisciplinary team with the goal of supporting individuals to live safely and effectively in the community. This includes interventions such as equipment prescription, development of home programs, environmental modification, and client/caregiver education. These interventions enable clients to achieve the highest and safest level of occupational performance possible within their home environment to avoid hospitalization. When not at work, Ted can usually be found outdoors with his young family, on his fat bike, or walking his dog. So thank you so much for being here today, Ted. We are so excited. And with that, I'm going to hand it on over to you.
Hi, good morning, everyone. So like the little bio said, I'm Ted. I'm an OT or an occupational therapist, and I work in what's known in the healthcare world as primary care. So the first stop, ideally, with the healthcare system would be a family doctor or family health team, or in this case, a family care team. And I am one of the team members on that team. So I'm just going to go ahead and try to share my slides. I do have 2 screens, so if you see me looking this way, it's because I'm looking at my slides on the screen to my left. I do speak a bit quickly, so I apologize. And if I tend to mumble, someone just let me know, and I will try to slow down and enunciate. Okay. Can everyone see the slide? Should say aging in place, a session for Seniors NL for today. Okay. So I'm not a tech whiz by any stretch of the imagination. I will make my slides available after the fact for people, and there'll also be a list of resources and some reading if people are so inclined. These are more so just to sort of stay on track for me during the presentation. It's going to be more of a verbal and ideally more of an interactive question and answer presentation. Bear with me, make sure we can screen through. So the agenda, I understand we have about 90 minutes. I don't know if I'm going to have a full 90 minutes of like sit down lecture style, listen to me talk, but we will cover the following stuff. So we'll talk about aging in place as a concept overall. We're going to look at aging in place in the NL context, and we're sort of in the middle of a systems transformation when it comes to health and social systems. And then we're going to look more at the individual side. So what you can do or how that applies to you individually, specifically for built environments and adaptive aids. And then we're going to open up for question and answer. So that's pretty much how it's going to work. I might have a quick break just for like bathroom or snack or get up, movement, that type of stuff somewhere in between. We'll see where we are. I'll probably do 1 break through it unless there's an ask to do more than 1 break or like a shorter period of time between. So as a concept, when we talk about aging in place has sort of changed over time. At first, or not, it's been around for a while, but it first really became sort of a policy construct, we'll say, um, earlier on. So historically, the baby boom generation, so anyone born between 1946 and 1964, was a large cohort of the population. And as that cohort has gone on, um, now what we're seeing is a lot of those people are getting older. And now we're looking at a large cohort of the population is going to be older and is going to be experiencing the changes that come at the latter end of the lifespan, basically. So aging in place has been something that really they've been looking at supports to live in the same home or community safely and independently as you age. So a lot of people are happy where they are; they want to stay there. There's a lot of evidence to support that that is better for people for a number of reasons. But initially in 2012, the federal government took out a document and they basically asked citizens to sort of start doing their own planning. So consider like what you would have to do to your home or in their community, how they would get around, the type of social supports they wanted. And that really sort of generated the policy idea of age-friendly communities. So an age-friendly community is, and I hope everyone can see this. It's sometimes when I share the screen, it's a little bit hard to read the fine print. But basically, there's three components, or at least in this theoretical model. So there's the built environment, which is the top. There's a social environment, which is really important. And then there's community health services. And I think when we look at healthcare as a system, when it was sort of envisioned and designed in the 60s, a large cohort of the population were probably in their early 20s or 30s. Um, People needed to have babies or they needed to have a short acute incident. So you went into the hospital, you got treated, and then you left and you were fine. And there wasn't a whole lot of community supports. But as we've moved on, we've started to notice, especially in the healthcare system, that social supports or having a robust system outside of just institutions also helps greatly with people's health outcomes. And there's a lot of evidence to support that over time, and the demographic stuff are changing, and we're really starting to take a shift from going into the institution to moving out in the community and meeting people where they are and trying to prevent instead of reacting to the broken leg or the need to deliver a baby or things you would typically see in a younger population for health needs, but otherwise we're pretty healthy. So in this particular model, when we look at the social environment, things that have become really important are things like social participation. So we hear a lot about isolation and loneliness in seniors. It's become a real area of focus lately, and we'll get into that a little bit in the Newfoundland context. Ageism has always been a factor, I think, to an extent, be it towards the earlier end of the lifespan or the older ends and somewhere in between for different generational stuff. But making sure there's mutual respect and social inclusion for all people, particularly those who are older, and then civic participation and employment. When it comes to community and health services, we've really moved away from an institution-based model and we're starting to get more into the community model. So, as people consider aging, they want to be closer to the services they need. Sometimes it means being in a closer to a larger healthcare facility or access to certain things. But the important thing there is that they have access to health and community support systems, as well as there's good communication information about what's there, what's available to them. And that's really the health services realm. So we're not going to get into that too much more until we get into the Newfoundland context. When we look at the built environment, outdoor spaces and accessibility are things like buildings. So, I think for a long time, people have always associated accessibility with wheelchair users or being handicapped, but it's more than just that. And also, and a big one that's come up here, especially in rural and remote communities. So I don't know where all of our participants are from, but I live in a fairly rural area. By the federal definition, everything basically outside of St. John's or the St. John's metro region is considered a rural and remote community. So, transportation is not the same in all communities. In a small, airport community in central Newfoundland, there's not going to be a bus system. There may not necessarily be a handy accessible bus where people can be picked up and taken to their appointments. Sometimes there is, but it's not the norm or the standard. We'll put it that way. And then we talk about housing, and housing is a big, as As a society, it's become a bit of a commodity. People are living off of becoming landlords. They're having issues with, basic affordability. There's not as many houses built as there needs to be to, deal with changing demographics and that type of stuff. Either seniors housing or, on the other end, family housing for newcomers to the area, or even just new families that move in for economic opportunities. So housing is a big thing that plays in the environment, and that's really where we're going to focus a lot of our attention today. So there's been a series of groups, and over time, aging in place has sort of changed a little bit. So at first, it was, like individuals within the population consider about how you would get around if you couldn't drive, or what you would need in your house and that type of stuff. And that was aging in place. And a lot of people said, I love this house. I want to stay here. I don't want to leave. And then, as the research came out and more people started getting into this, in 2022, they put out a report. So this is the Institute for National Institute on Aging, and they put a report about aging in the right place, which is a bit of I guess, a bit of refinement, really. And they looked at really changing aging in the right place, or AIRP, as the process of enabling healthy aging in the most appropriate setting based on older person's personal preferences, circumstances, and care needs. So I think it was, there's a few pillars there we need to really change on, but it hasn't changed too much. So you'll notice that they're promoting preventative and better chronic disease management is one thing. So access to health services, and ideally preventative, and for things that aren't just a short reactionary thing, but things that go on forever. Certain conditions are, they're not going to be fixed. They're just going to be managed. You're going to work with them throughout your life. Strengthening home and community-based care and support for unpaid caregivers. So I think what had happened is that they realized that in the institutional-based model, there was a lot of care. There was always, doctors and nurses and, specialists to help out, or different allied health team members. But when you went home, really, it wasn't the doctors, nurses, and the people that looked after you. It was your friends and family. And a lot of times they were really relying on sort of volunteers or family members or people that took on sort of the air quotes, the burden of care, when they might also be living other roles. So they might be a mother, a friend, a sister, or whatever, but they also happen to be a part-time nurse, or the person you call in the middle of the night, or it could be a clergy member. But there was a lot of these unpaid caregivers. And, as the population ages and we find that, people of the same age have their own care needs, there needs to be some more, I guess, support given to those unpaid caregivers. And that's one of the things we're going to talk about. So the other thing we look at is developing accessible and safer living environments, and that's really been changing. So that's more around the built environment, making sure that things work for everybody, and it's not just people in wheelchairs, because I think a lot of times that's the initial standard. Make things a little bit bigger, make sure there's a ramp, and it's all good. But there's more to design than just making sure that one type of person with a disability can be accommodated. And then finally, improving social connections and reducing loneliness and social isolation. So that is really, there is a big mental health component and a big social health component to aging well over time. It becomes difficult when you don't have as many social supports, or you can't get to places, or you are really isolated in a certain area because of a health condition or the consequences therein. So those are the main four pillars, and you'll notice that it's sort of from the built environment, health and social services, and social stuff from before. It's really sort of become a more nuanced understanding of what it means to age in place. So when we look at Newfoundland's specific context, is anyone here not familiar with the Health Accord? I think everyone is. I'm going to click on a link. I'm not sure if it's going to show up correctly for you guys when I share a second screen, so just bear with me. So the Health Accord was really a re-envisioning of the health care system, specifically in Newfoundland. So without getting into too many stats, Newfoundland was spending a lot of money, was getting poor outcomes, and it was really an institutional-based care system that needs to change because it really didn't acknowledge any of the social determinants of health. So basically, this is all about the awareness and the intervention for social factors that influence health. So If you have access to more stuff, if you've never had any issues with scarcity, or if there's just more things available to you, and you're more economically, like you have more choices based on your economics, generally speaking, those are considered social determinants of health, and they tend to lead to a higher quality of life and a better health outcome overall. And then we're looking at a balance of community-based systems. So primary care, which is where I work, which is basically your first interaction with a healthcare team, a system, et cetera. Elder care specifically, because we know that a larger portion of our population is going to fit into what's considered to be elder stages of life. And then looking at social care, so also helping each other out. So it's not just community-based, or excuse me, it's not just hospital-based, it's also community-based, because a lot of things, there's also some evidence to support that, like, when you spend a lot of time in hospital, you don't get to socialize as much. There could be an increase in like hospital-acquired infections and other just secondary outcomes from being around a lot of sick people and just being in a very busy place where you only get treated a certain way and not as an individual. In all cases, it's not individualized to you per se, and it's not in your own space. So, really, we're trying to look at moving stuff out of the institutions and into the community, and trying to prevent stuff before it happens, so you don't actually have to go into the healthcare system. So that's ultimately going to be a long process to change gears. And this is a 10-year plan. So I believe we're in like years 3 or 4 with the plan now. So we're getting there. And one of the things, I work on a family care team, and that is really a re-envisioning of the healthcare system, whereby you have a family provider, be that a doctor or nurse practitioner, you have access to a dietitian, you have access to social work, you have access to physical therapy. There could be other team members like psychiatry or wound care, or things you wouldn't typically find in your standard doctor's office. That historically had been the starting point for everybody. You see the doctor once a year, you go to the hospital if you need something urgently, right? That model is, it needs to change. We're having a lot of issues with that. So that's pretty much what the health court is. So I'm just going to get back to my screen. Just bear with me here. I'm going to pause my sharing. Okay. Can everybody see my slides again? Yeah. Okay. So that's the Newfoundland context. So that's this health acknowledgement of social determinants of health and trying to incorporate that in the healthcare system. That's ongoing, and that's part of the health accord. And you'll see a lot of funding going into health and community programs via that area, specifically for what's called primary care, your first step, or your first stop with, or first contact with the healthcare system. Now, when we look at specifically for seniors, bear with me here, see if this works. This should come up. Okay. So the provincial government, which is what regulates healthcare in the province of Newfoundland and Labrador, there are federal benchmarks or outcomes that we're supposed to meet, but it's all managed provincially. Okay. So GovNL, or Government of Newfoundland and Labrador, they have a lot of healthcare action. So they've made a lot of changes lately around like mental health, seniors care, the health court in general, and just really trying to reshape the transformation. This is an area where they're also looking at seniors, the health and well-being, specifically for aging in place. Now, I was told that initially when I shared this video, you guys couldn't hear the sound. I'm going to try it one last time. If that doesn't work, I will get, I guess, someone else to sort of send it out with my slides. You can just watch it after. So my apologies. Sound? No sound. No sound. Okay. So
I can't,
guys,
but I can go ahead and share that with all the folks who are here today after.
yeah, maybe just put a link in the comments and people can probably click on it. It's
Yeah.
probably easier. So in a nutshell, what they're looking at the end, because there is, even without the sound, I'm just going to play the text just so you can see it. So they talk about grants to help with daily chores, food and heating, or just cost of life stuff. There's grants for home mods. And there's some supports for people that might be on the lower ends of the socioeconomic spectrum, specifically seniors on a fixed income. Um, and we're trying to really promote that. Okay. So really, they've established a couple different areas and they're starting to fund it. And like 70 million sounds like a lot of money, but it's healthcare is very, very expensive. And there's a lot of people. And like, I think on average, if you consider, I think we're paying something like $11,000 per person, or that's one of the last like federal numbers that went through there. Um, on average every year. And like if you're in the hospital, it's something like $1,500 to $2,000 a night to spend time in the hospital. So if people go in the hospital for months at an end, like it's just it's a really, really, really expensive thing, no matter what. Um, so what the well-being initiatives really look at is more the social services. So they're looking at basically aging well at home and having some money to help out people that couldn't otherwise afford it with supportive services. So things like snow clearing, grocery delivery. And we'll talk about those are considered to be social services when you consider aging in place as a concept. There's some more for like caregivers, so acknowledging that like unpaid caregivers really do a lot of work and really deserve to have some they need some money for that ultimately because they're giving up their own spare time and sometimes even their own health um, because they're just constantly doing stuff and also looking at things like respite care, secondary caregivers, and that type of stuff. And then finally, they're looking at increasing the grants and stuff that are available for people that qualify based on their income to make modifications to their home to make it more age friendly. So that's the government plan currently. Um, but just this past month, bear with me, um, the the Office of the Seniors Advocate put out a plan or call to action, basically called "An ounce of prevention is worth a pound of cure." So that just came out this past month, and it's a long read. It has some stuff around demographics, aging in place, and it's really focusing on some things. So I'm actually going to pull it up in just a second, and we're going to go through a little bit there because it is useful. So just bear with me. Okay, guys, can everybody see that? Yes. Okay. So this is the actual report. It's fairly lengthy. Um, and I apologize. We're not going to go through line by line. It is here, but basically, what it talks about is aging well in place as a concept. So the Office of the Seniors Advocate knows that people want to stay in place, or they have data to support that, and they go through some of the data. I can show you a couple of things. This talks about the cohorts, the population, what their ages are. So in general, we have a lot of people that are in the 60 to 64 range, 65 to 70, like 60s, 70s. Um, this is a big cohort. And in the next few years, we're going to have more people sitting in that cohort than any other, right? And this is not just males and females as well. So there's lots of people there. Um, aging in place, they talk about the four pillars we talked about with the aging in the right place. So improving social connections, accessible living and safer living environments through the built environment, strengthening home and community-based services for unpaid caregivers, as well as preventive health and chronic disease management. So it's not just a one, I broke my leg, I went to the hospital, it got casted, and then I got sent home. How do I live with dyslipidemia? How do I live with type 2 diabetes? How do I live with, chronic arthritis? That type of stuff. Things that aren't just going to be fixed. They might be managed or improved, but they're not going to go away. When we talk about changes here, survey demographics. So they surveyed a lot of people across Newfoundland and Labrador. Some of you guys might have participated in this. And basically, there's a cohort of the population that has a lower income, and there's a cohort of the population that has a higher income. And unsurprisingly, the majority of people have a lower income than the higher income over here, right? And there's a lot of people in this like 65 to 75 or 74 range, or 75 to 85 range that applied. So generally speaking, older, not actively working per se, might have some sort of like fixed income pension or OAS, CPP, that type of stuff. Generally speaking, is not the same as a labor market job. You're not making $100,000 typically off of those types of funding. These are the people that responded. So most of them are in St. John's or the St. John's Eastern urban area. There's some places in rural, but for the most part, it was more of a, it's a higher cohort of Newfoundland's population just lives on this tip of the Avalon anyways. Okay. I'm going to move forward right to the recommendations of the report, and we're going to go right to page 23. So in a nutshell, it says the demographic data shows the two largest cohorts of seniors in Ella are somewhere between 60 to 70, we'll say 60, 69. Okay. And, over time, that's going to increase as they get there. So there's more people. Generally, as we age, our healthcare needs increase. The Health Accord, which is the health and social care transformation we talked about, it's probably year 3 or 4 out of 10, notes that more people and seniors in Ella live with 3 or more chronic diseases, which is higher than the national average in Canada. Okay? And if we are going to look at where we should focus our stuff in terms of area, well, there are many reasons for lack of proactive planning. Many barriers, main barriers are cost, lack of knowledge for who to contact to make changes, and what changes to make, or even if there is a need or guidance to make changes, right? So I just want to say here, and this is right out of the report, seniors advocate, prevention is much, much more important than just making renovations to your house and getting some assistive devices. But these are primarily related to this area since they were the focus of this particular report. Okay, so this is fairly new, and the biggest barriers are really cost, knowing who to call, and having someone do some of the work. Okay, so there was a few recommendations that the seniors advocate put out. So basically, the first two are related to education, and they really come from a government level. For anyone who's not familiar with the way the government is set up, the provincial government, or the Department of Health and Community Services, is the government department that administers healthcare. Newfoundland and Labrador Health Services is an arm's length. They're a separate entity. Okay, so they're basically a corporation that's designed to basically follow through. So these guys make the rules, make the plans, come up with the vision, and then we are working back and forth here at NL Health with the government Department of Health and Community Services, but they fund all our budgets for staffing. They're the ones that come up with how they use tax dollars and what initiatives are going to go through. Okay. And so really what they've recommended is that Department of Health and Community Services develop and annually update a seniors-friendly how-to guide with evidence-based preventative practices. So things that people can do to prevent stuff from getting harder, decrease quality of life, that type of stuff, and make it available to anyone who wishes to adapt to their environment, the information, how to access these programs and services. Okay. So that's really more about education, telling people what to do, where to find it, disseminating that information. Okay. And then finally have an education campaign informed by the how-to guide. So that's what to do. And then we go out basically with a marketing blitz to talk about it, to help guide and facilitate the public to take preventative action with home modifications and assistive devices to maintain health as we age. So this one's near and dear to my heart because technically I'm an occupational therapist. So occupational therapy and physical therapy, or physiotherapy, are basically the two rehab professionals. But we're getting out of just doing rehab because that's more preventative. So that implies that you had something bad happen and then we have to help you fix it. And now we're getting more into the preventative stuff. But basically, there's a call for Department of Health and Community Services to expand access to more community physio and occupational therapy assessment programs and services as preventative measures. Okay, so not just reactionary. There is a note here, if anyone's familiar with the Home First program, essentially what that is that's a philosophy of care whereby if someone came into the hospital, we do everything we can to get them home first and keep them at home if that's what they want to do, instead of having to put them, into an institution or a different area that they may not prefer to be in, but may not have a choice given their health circumstances. So we look at home first, and that's really a reactionary approach. So when someone has already had an incident or already the situation presents itself instead of preventing it. So home first is good, but it's reactionary. The preventative stuff is really what they're calling for here. So I just want to distinguish between reactionary and prevention. Okay. And then the other thing they're talking about really here is increasing access to stuff. So, making sure there's coverage for things like grab bars and rails and canes and walkers, increasing funding. And the existing home modifications program grant, it does require that you see an OT. You can't get into it, you can't apply for it unless you have a certain income threshold. I believe at this time it's like $46,000 annually as a household. Now, it might be individual level depending on how you apply. Um, but for all intents and purposes, there's a lot of people that fall just outside of that that aren't financially able to just renovate their house, or they can't just come up with an easy amount of money to make some of the changes that are really being called for prevention, and that ultimately would pay dividends, but you need to have that upfront cost. So what they're looking at is really changing some of that. So they want like very small, cheap modifications, things like grab bars, anti-slip tape, handrails to be funded without having to see an OT, because that is a bottleneck. There's not many OTs in Newfoundland, like compared to the population. It's it's hard to see those people. Um, and then finally, they talk about raising the threshold, basically. So, pretty much doubling it. So if you make under a certain amount of money, it should be covered for you. Okay. Any questions about that before I go on? Just type them in the chat, I guess. I can't quite see what's going on there in
So
the
I
chat.
don't
Bear with
see
me.
any in the chat as of right
Okay.
now. But I
So
can.
guys, we're at about the halfway mark. I have about 40, 45-ish minutes there. Can we take like a 5-minute break in case anyone has to go bathroom, nutrition, just get up, stretch, walk around, that type of stuff? And I'll stop sharing my screen, and then we'll come back. We'll talk about the individual stuff you can do.
Perfect. Sounds good.
Okay,
We'll
we'll see you in about 5 minutes. So
10.
about 10:10.
Perfect. Sounds good. Thank you,
All right.
Ted.
All right, guys. Welcome back. So this is the part where we're going to start looking at individual considerations. And can everyone see my slides? They don't look very pretty right now. I'm trying to get them back up on the screen, but they're being fickle. Um, so what we're looking at now is sort of what you can do as an individual to help plan for aging in place. If you feel like you're sort of there already, that's okay. It's never too late to start. But these are the things that, ideally, even from the age of like 50 onwards, people should start having conversations with, first themselves and then probably their loved ones or anyone that's in your life that, is important to you, because we all age, ideally. And it's something that really, it's more than just something that happens and that, oh yeah, well, I'll deal with it when I get there. It's something that you can really impact earlier on if you make planning. So let's talk about basics. Okay. So before we get into home modifications, we're going to talk about a few things. So things like legal paperwork or having certain things done. So I'm sure not many people are aware, but April 16th was Advanced Care Planning Day across Canada, and was brought to you by Advanced Healthcare Planning, which is a national organization, basically talking about having health directives, okay, and making sure you guys are talking about that and getting people aware. So if anyone is not familiar with that, the most probably, it doesn't incorporate everything, but the most common thing is a do not resuscitate order, or code status. Most people might be familiar with that from the hospital. Um, Advanced healthcare planning goes to more than just that, but the DNR is probably something that most people would be at least hear about in like medical dramas and shows and stuff. But in a nutshell, it just comes down to having conversations with you, yourself, as well as the people that are close to you or in your support circle, and just talking about really what are your wishes. What do you want to have happen? And this is not something. It's different from a will, because a will is what happens after you're no longer alive. Healthcare planning is really what happens to you if you're not able to make decisions for yourself, or what decisions would you want to make, and talking about your family. And that's part of that. And then making sure that everyone's sort of looped in, they're written down somewhere. It makes it easier for anyone, should you have some sort of health event or something where something unexpected happens and you just can't make those decisions for yourself. Of course, having a will and a power of attorney is useful, and some things that really need to be established if you have dependents. And some people think dependents are like children or family members, but also like pets. Who looks after them? Where does that responsibility fall if you're not able to do that, as well as all your stuff? So that's important to sort of consider. And then, while you are still alive, the most important thing is, a lot of things now are no longer pen and paper. You don't show up with a pay stub and go to a bank and pay all your bills at once. A lot of them are now automated. So they're auto pay or they're direct deposit or whatever. Um, and there's an app for pretty much everything now, and it gets really, really confusing because they constantly change. And you have to set up these passwords that are like inane and almost impossible to remember from time over. But ultimately being an independent individual that is able to look after their own finances or, the finances of a household, we'll say, a lot of times that information has to be recorded somewhere or shared. There has to be some way to share that. So like, you know, historically, and I used to work in a hospital, but what we used to see is that someone would do all the finances and someone didn't. And then that person would get sick or not be able to do those finances physically because this person didn't drive or didn't know about them. And there was a lot of issues. And so making sure you talk with whoever you're involved with to make sure that you know how to access the essentials. So things like bills, legal wills, insurance, licenses, deeds, surveys. But not only that, but also just how to get access to certain things. Like there's a lot of online or digital infrastructure now for like everything seems to be moving away from pen and paper. It's all click on the app or use your phone or iPad or device. And all those login passwords, they're hard to guess. You can't just make them up again. It's not easy for someone else if they have to step in to, you know, work on your behalf, we'll say, to do that. So making sure there's a place there where some of those things are recorded, or at least there's a plan in place where someone might be set as a secondary or an adjacent on the account can really help. So those are sort of like legal financial things you can consider. And they don't have to be considered to age in place, but they are very, very useful if they are already covered. Aging in place caregiving. So at some point, we all need some help and we all try to help out, essentially. Will I need to provide care to my loved ones, multiple? And sometimes it's not even so much an expectation of, oh, well, when we're old, you know, I will need help and she'll help me or he'll help me. Sometimes it's like, oh, well, Granny will have to look after the kids for the day so that mom and dad can work. Or granddad might have to help with, son-in-law because he doesn't know how to fix stuff. That type of stuff is really, really common. But are you aware of sort of if you were to become an informal caregiver or an unpaid caregiver, we'll say, so you're not a full-time nurse, it's not your job, you're not a person support worker or what have you, are there resources available to help you out? Are you familiar with what they could be? Um, and then ultimately, do you need to make a self-care plan to make sure that your health is as good as it can be? So those are things that you can look at there because some things are very, very much preventable with early intervention or lifestyle changes. But after a certain point, it becomes difficult, and there's really, really foreseeable changes that will require caregiving at some point in the future. Getting around. So when you consider getting around, aging in place is also about social and health services, but it's as much about access to services. And many people will typically outlive their ability to drive due to medical conditions. So it could be anything for visual changes or some sort of cognitive change, or even just people just don't want to deal with the stress anymore, depending on where you live and what it's like. So it's important to consider what will happen. Like if you don't independently drive your own vehicle, or if you've never driven a vehicle, how do you get your stuff? Like, is delivery an option? Will someone else drive for you? Because out our way, there's no transit system. There's no other options. Basically, your options are people and friends to help you and drive you around, or paying privately for taxi cabs. In bigger cities, you might have like ride sharing apps where you pay strangers to help you, basically. But at the end of the day, these are things you have to consider. And I think a lot of people just assume that they'll be able to drive until they're dead, and that they'll be able to get everything and they'll be able to gas up a car and maintain it and do the brakes and store the wheels and all that. But you may not be able to do those things. So consider, how you're going to get around. Okay, so this is where I want to focus most of the stuff, is the built environment. So for all intents and purposes, we're going to consider the built environment anywhere where you live, walk around, basically indoors, whatever you want to call indoors, and even to some extent outdoors, when it comes to things like benches to sit on, or level ground, or firm pathways, or anti-slip matting and that type of stuff. Um, so if you have a home, not everyone does. If you live in a current home and you want to stay there as you age, what do you think you need to modify that to make that there? So a lot of people foresee that like steps might be an issue over time, or that they might need, a way to call someone or have some sort of help come in. And a lot of times people also try to get away from some of the home maintenance that comes with a larger home. So, like if you like around here, there's a lot of people live in a multi-level home. In the basement is a wood-fired furnace. And so that requires chopping however many cords of wood you may burn, carrying it down the stairs or putting it through a chute, going into the woods to harvest that wood, cut it up the year before, stacking it, storing it, letting it dry. So there's a lot of work to certain things. So if you're going to maintain your home, is there a service to help you do that? Is there a family member? Will you have the money to pay for that type of stuff? Because as you know, cost of living has increased dramatically. A quart of wood is not what it used to be. And, depending where you live, it may not even be available without a lot of inconvenience or great cost to have someone bringing it into you. Do you need to move into something slightly more manageable? Um, what are your housing options if it doesn't meet your needs? Because a lot of times people say, oh, well, I'll go in a home, but it's not as quick as that. You may not just be able to sell your home. You may not be able to just move into the next available stuff, even if you are financially eligible or able to just do that. There might be a wait list. You may not be, it may not be there. So we're going to talk about the housing spectrum a little bit. Generally speaking, um, you know, large family style houses, multi levels, lots of stairs, big property, lots of things to maintain. So fences to paint and build, and steps to maintain, and lots of square footage to heat. Um, that's sort of the upper ends of what we'll call the labor spectrum for home ownership. And then when we move down through the spectrum, as we move down, we have almost like a downsizing. So, you know, bigger stuff, more personal onus, less personal onus, generally smaller, maybe not. Might just be different design. So, you have things like smaller, like cottages, one level apartments, in big buildings could be nice. There could be multiplex. So you live next door to somebody else that helps you out. Some people want duplexes, triplexes, townhomes. Your neighbors might help out or come over for a meal for social interaction, that type of stuff. And then you also have like sort of the adjoined apartment. So, you know, apartments are nothing new, and I think they've almost become a bit of a financial necessity to home ownership in some cases in the last probably 10 years. A lot of people can't afford to buy the house or pay the mortgage without the income from the basement apartment or some other, you know, version of turning a housing into commodity. But ultimately, like this can be a really, really good option for someone if it's laid out well, because you can be nearby somebody if they're a loved one that can help give you some support. So that was typically known as the granny flat or the granny suite. And in some of the bigger municipalities, you're seeing now funding for secondary housing, like smaller housing buildings on existing properties to help out with some of this. And then ultimately, you have the home or the homes. So institutionalized care. So in this province, the private system has like personal care homes. The public system has like long-term care, which is like 24-hour nursing care, and there's degrees of how much care is provided. But generally speaking, um, they would do a lot of the work that you would have to do before. So like they cook your meals, you might have like recreation brought in for you. Typically they're better designed for a certain like cohort of the population when it comes to accessibility and like space and that type of stuff. So that's pretty much the housing spectrum, and there are things to consider there. So if assuming you have your own home, and we're looking at ways that we can basically retrofit or maybe modify some stuff. Um, Bars and rails, anything to hold on to is good. If you have stairs that can't be otherwise changed, stair lifts are sometimes an option. They may not be a great option, but they are an option. Um, Taking bathtubs and turning them into walk-in showers or anything where you have to avoid having to step over a 20-inch wall or step into a slippery, usually poorly lit area is good. Um, Some people have a hard time with getting down to what used to be a standard height toilet, which is like 15 inches high. The standard seems to be creeping up to like 17 or 19 now. And most of the newer toilets you get are called comfort height. They're somewhere in that 17 inches to 19 inches high. They're a bit taller. Also, some people have issues with like twisting, reaching, and wiping, and bidets have become a much more popular option. You can even retrofit your existing toilet with a bidet for that type of stuff. Generally speaking, housing as designs have become more open concept. It's pretty trendy right now. There's less sunken living rooms with steps. There's less 90-degree turns and stuff down hallways where you really can't get a full turning radius. Now things seem to be an open area with an adjacent separation for private space. So like a bathroom is there. Typically doors have become wider, and in some cases, instead of having multiple steps or just one big concrete pad, they might just gradually grade, um, like with asphalt or just a ramp. So ramping, grading, any exits or doors, or changing up how you get between those different levels. When it comes to bathroom equipment, this is pretty, there's a lot, basically, and they're constantly building new stuff. So generally speaking, when we talk about um, a bathroom could be either be, it's usually, if it's powder room or a half bath, there's usually a vanity. So it could be a pedestal style sink. If there's no cupboard, sometimes it's a full vanity with a cupboard in there. And what we see a lot of in my world is that people are using the vanity with the countertop as like a grab bar because it's next to the toilet, and people are sort of grabbing and pulling and they're reaching for stuff, or it's a bit awkward. So there's all sorts of ways you can change that. Please never pull from pedestal sink. They're literally just very brittle, like porcelain, and they'll crack. Also, you'll flood your bathroom if it breaks the pipe underneath. Um, so that's just a couple little safety tips there. But usually when people think about bathroom equipment or bathroom renos, the bathtub or the shower is the area of concern. So when we look at, general changes you can make, typically speaking, this is going to be across the board, but removing stairs or steps and using ramps. If you're, it's pretty, hips and knees all have issues over time. Sometimes they can be managed with exercise and lifestyle and that type of stuff. Sometimes with surgical intervention, but you still have to go through the exercise and lifestyle after the surgery. And it's just easier sometimes just to have roll and roll out. Like I'm a dad, I have pushed strollers. No one likes to have to carry those upstairs. It's just easier to roll stuff up, honestly. So ramps are ideal. A lot of people don't think of this one, but increasing lighting and having high contrast. And I'll show you an example of what that looks like a little bit later on. But in general, a lot of times people have falls because they're so weak or they got dizzy or woozy. Typically, they missed the last step and they fell down, or they didn't see something, or they thought it was they didn't realize the floor was wet and they just slipped. It was a very small thing, but they fell and they broke something, and it was pretty consequential to the lifestyle after. Increasing lighting can really help people spot hazards better, and having good contrast, especially on stairs, is super, super useful. When it comes to building stuff, the bigger the better, generally speaking, for accessibility. There used to be a time where like there was almost like a 24-inch closet door that would go to the water closet. And there's no way for you to get anything. Like if you have to have a walker or a wheelchair, there's no way for you to get that into that bathroom space. You basically just have to remove that door and maybe cut a wider opening. But depending on the structure of your house and the age, that may not be feasible for you. So a large, wide open concept is generally speaking better for aging in place. It also helps out with things like lighting. You don't have as many shadows and smaller areas to shine light around. This is less of a thing now. I feel like high pile carpet or shag carpeting or the really deep plush carpeting of like the 90s is not as common as it once was. Not only for bacterial reasons, because it does harbor stuff when it gets wet, but just in general, I feel like laminate flooring and just variations of non-slip, smooth flooring that people can roll over or walk over has really just come a long, long way. But if you do have high pile carpet, it's really hard to push a walker or a wheelchair through like this much like soft carpet, or even put like a hospital bed on top of that or move around. Um, this one's just more of a housekeeping thing than anything, but removing clutter and tripping hazards and also having good lighting so you can see them really does prevent a lot of falls. You can tape down any area rugs or anything you put on top of the existing floor. A lot of times people get their foot caught in something, and that's what sort of sends them down for a fall. Lots of handles and railings. You want to have a place to, have good balance basically. So the more points of support you have, the better off you are, the less likely you are, or the lower your risk will be to have a fall or have any issues. And then ultimately, if you are looking at changing like a big change, easier to maintain heating sources. So I think I alluded earlier to like really labor intensive, like having to go down and check the oil furnace or having to put wood in the wood stove. But like a lot of times people too want to have like where the climate is getting warmer, want to have air conditioning as well. Heat pumps are a great way to go for that. They may not put as much heat as your wood stove or as your furnace, but having easier to maintain heat sources are things you have to do. As you get older, it does become a bit safer and lowers your risk. Main floor utilities and storage if possible. So a lot of times people have a 3 bedroom, 1 bathroom house, and in the basement is where the washer dryer is, and they have to go down 12 steps. And it's a poorly lit basement, and the only place you can get the light switch is at the top of the stairs, not at the bottom. And so, someone turns it off on you by accident, and then you're in the dark. And anyways, so that's the type of stuff where if you can move everything up into the main living area, that works out better overall across the lifespan. When we talk about transportation or even just difficulties getting out and just certain like poor weather, um, Newfoundland's not renowned for its awesome weather, and winter is getting a little less. Snowfall fluctuates a lot. Sometimes we get a lot of snow, sometimes we don't. But if you can look at options for delivery, for things like essential foods and medicines, that's useful, and that's become a real service that I think is sort of taken off in the last little bit. Like most pharmacies will have some sort of delivery or option for that. You can also do like pickup, so you just drive to the parking lot, someone loads in your groceries from Walmart, for example. Um, Making sure you have non-slip footwear and something that has a back, that has an ankle strap or goes around the back that has a really firm back. So not flip-flops. Please don't step on the back of your back wall of your shoe and fold it down and have it move around. That's a really, really common way for people basically to trip because they didn't trip, but their foot got stuck in something and it caused them to trip. That makes sense. And then ultimately, if you are concerned about, living alone or having something untoward happen to you where you weren't sure if you'd be able to call someone right away, consider like a safety alert device or having a cell phone or some other way to contact somebody that's there. When we've been talking about this historically as OTs or physios or anyone in the past talking about falls prevention, it's really been to try to prevent fractures and hospital admissions and that type of stuff. But as technology has gone on, they've also like there can also be alerting devices. So like if someone is like has like a dementia or needs like a learning device, like they can even be tracked now, basically. So if someone goes wandering, you can ping their phone and you can find out where they are. Like that type of stuff is invasive but useful for safety sometimes. Okay. Um, so I'm going to show you a couple pictures. Can you guys see the screen? Yes. Okay. So it's very hard to tell. The one on the left and the one on the right are the same bathroom. No, there's not a toilet in the shower. That's just the reflection. So this is sort of your standard 1990s, 1980s bathroom. There's a vanity, there's a small lower toilet, and then there's like a very small bathtub with like probably a 20-inch wall. And then sometimes there's sliding glass doors that go over top of it. Typically, there's not good lighting in the shower, so it's dark. There's like an opaque shower curtain you can't see anything through, and then you're stepping on a wet, slippery surface. And it could be even worse if you have like spilled shampoo or conditioner or anything that's really, really slick. This area is thought to be where a lot of people have falls, whereas on the right-hand side is a renovated bathroom. Now, obviously, this renovation is not cheap because they have marble throughout. But you can see that there's places to handhold. So there's a glass door, there's better visibility, there's something to hold on, there's a shower that's adjustable in height, so multiple people can use it. It's not, short for the tall person and too high for the shorter person. And you can't see it here, but there's actually a built-in shelf or a place to sit and shave your legs or sit down if you get fatigued, that type of stuff. Okay, and then on the other side is a toilet and the vanity. So that's an example of like a very, very common sense basic modifications. You took a bathtub, you removed it, and you turned it into a walk-in shower. But things to consider are grab bars, where they're placed, and ideally in lighting from the top down, like good lighting. And if you can't do that, then have something clear so that the light at least shines through. Okay. Um, I talked a little bit of contrast. I don't know how well this shows up on your screen, and I apologize. I'd like to make this bigger, but I can't. These are actually the same stairs. So the difference here, and yes, it does make your house look a little bit industrial. Okay. But I will say that you can actually see, and there's a second railing that's been installed. So both railings are in yellow. The ends of the stairs are in different colors. So the first step and the last step are denoted in red, and that's so people don't miss a step and fall, or they're not looking for one. And you'll notice there's a black and a yellow step. That's because it's an oblong step. You'll notice the stairs aren't quite, so that's the last one, and then the last red step is actually a little bit longer. Sometimes, like I've seen some wonky houses where people have like sort of built their own stairs and they've been really like really narrow or really wide and they're not quite all true. Unless you know where you're stepping and you expect it, that can really throw off someone's gait or sorry walking pattern if they're not used to it. Um, and wherever possible, anywhere on stairs or anything you have to climb or traverse, ideally 2 points of contact for the hands that you can reach on both sides. Sometimes people have this big, illustrious staircase, think of like the Titanic, but you can only reach one handrail. Looks great, but practically speaking, you might need to use a cane on one side or something else to add a bit more stability. I'm probably preaching to the converted here, but having visual alerting devices as well as audible alerting devices, some of these things are just building code now. But a lot of times, like cell phones, they can be programmed to flash. So if you can't hear a buzz or you can't feel a vibration or whatever, they can flash. And same for landlines and a few other things. Like things have become a lot more what I'll call air quotes accessible to more than just people that can't walk in time. So, I mean, I don't have a whole lot more to share other than just different types of adaptive aids for like the kitchen and different things you can do. And then I think we'll probably open up for question and answer periods. I understand some people are leaving soonish if they haven't already left around 10:30. So hopefully they haven't missed too much, but they can always check back. So when it comes to just general adaptive aids, there's no funding for these currently under the existing programs in Newfoundland that I'm aware of. You might be able to submit them back to your insurance if you have private insurance through like a former employer or a current employer. But there's basically you're paying out of pocket for these. So I'll just put that out there. So a lot of times people, as they age, they have just hand pain in general. Arthritis and other conditions can really impact, your ability to grip and grasp and twist. These are all ways that you can do that. So generally speaking, anything that helps hold on. So basically the jar goes in the center here, and then you have a longer lever to exert more force. So you don't have to do it from your wrists, which hurts sometimes. And ultimately, these are some of these things you can tighten on and then twist, get you a better handhold or grip. Sometimes there's under the cupboard version. So this is like sort of a universal one. So various sizes, you can just sort of stick under the cupboard and then two hands and twist. Okay. So if you ever get stuck with jars. Likewise, people have issues with twisting doorknobs itself. Levers are now the standard for accessibility and for universal design, just because they're easier for everybody to open. But if you don't have that, or if it's just not something that's up, you can just easily change. There's all sorts of adaptive devices, or you can even travel with these if you're going to someone else's house, and you have like a lever you can put on there. Okay. Likewise, if people have a hard time with arthritis or like fine grasping for pens, razors, knife, fork, spoon, etc., you can build up handles with soft foam to make things bulkier and a bit softer to hold on to. Sometimes that can extend, like if someone wants to be coloring with their grandchildren, you might not be able to tolerate that very well, but with this, maybe you can. If you have the dropsies, so if you have intermittent hand weakness or numbness or anything where your hands are semi-unreliable when it comes to holding on to stuff, or you can hold on as far as they start to shake and get weak, these are universal handles. So you can put them on pretty much anything. There's different sizes. They're not perfect, but they do help out for certain things. Likewise, there's a lot of tech that can be added now to the house. A lot of things have become like automatic. So, instead of having a manual hand crank, you had to squeeze to punch it and then twist and get all the way around, which would be pretty onerous. You can just put that on top. It'll go in and then just take off the cans. Likewise, there's different designs for knives now as well. So like if, you can exert more force with less effort on your end, or you can be in a more ergonomic wrist than you would if you had to hold this way, if you held neutral wrist. So there's that type of stuff. And then also, some people have like conditions that cause like tremors or weakness or just discoordination. There's all sorts of stuff that can go on here. So plate guards basically make a wall around your plate so it's easier to scoop stuff up or turn it into a bowl. Ultimately, or if you don't like the look of that institutional little clip-on visor, you can also get like taller, basically plates with walls. They're just more expensive. That's all. Um, I think handled cups and things with covers just to avoid spills are pretty straightforward. And sometimes you get two handled cups if you have a weaker side or a stronger side, or you just have two weak sides. Suction cups, or excuse me, suction bowls and plates. So if you have a hard time moving stuff around, that can actually hold it right to the placemat. And you can also get high friction or good gripping placemats so things don't slide around even without the suction cup. So they're the anti-slip mats. This one's a bit hard to see from the photo. This is a weighted utensil. So if you have a resting tremor or something else, that's about a half pound, that spoon. So the goal is that that would actually dampen some of that. So you're not just shaking your stuff off your bowl and you can continue to feed yourself or, eat your favorite food without losing half of it on top of you. Okay. So guys, these are just examples of things and there's literally a whole bookload of stuff. Wheelchairs, shower chairs, commodes. There's oodles and oodles and oodles of stuff. Bath lifts, if you can't retrofit a tub for whatever reason. Risers for toilets. There's hospital beds and mechanical lifts, which are probably outside the scope of what we're doing here for prevention. Different slings. There's grab bars. There's transfer boards. There's all sorts of stuff. Bed rails are another useful thing to help with positioning, either for turning over in bed, staying in position, or getting up sometimes. It's basically a grab bar for your bed. Walkers, rollator walkers, canes, lift out chairs, and various types of seating. So, I'm I'm open for any questions you guys might have. Typically, I work on a one-on-one basis or with a family, so I'm used to more just sort of case-by-case examples. But generally speaking, anything you can do to increase the lighting, remove the need to stand in a wet, slippery surface. So if you have a chair or have a built-in seat there, that can be good. And there are cases where having a built-in step or a built-in seat inside a shower is not always good, depending on the diagnosis. But we can talk about that on a case by case. So I guess I'll open it up for questions. And I guess we have 5 minutes or 3 minutes. And if there are none, then I guess that's the end of the presentation.
Perfect. So I will pull up the chat here just to keep an eye on if any questions do come up or anything. But
Yeah.
I do have a question actually that came up while you were chatting. And first of all, thank you so much. So much useful information in there for all of us to have. So I really appreciate everything that you've shared today. But one question that came up for me is about the home modification program and like seeing an occupational therapist to kind
Yep.
of get approval for the modifications or whatever it might be. If somebody's interested in that, they think they might be like it might be useful for them to get some home modifications. What is the process? Like, how do you kind of go about engaging with that program? Some people have family care teams, some people don't. So what does that
Yep.
kind of look like, that process?
So I'm trying, just bear with me here. I'm going to look over my other screen. Are you guys familiar with the grant itself? So like there's a home modifications grant through Newfoundland and Labrador Housing. It used to be Newfoundland and Labrador Housing Corporation. I think it changed its name recently. In essence, that's a third party through the provincial government, and they don't care where the OT comes from. So whether that be a community supports OT, so you might have like a local community health center where you get like your COVID-19 vaccine, for example, like that area. You might have to put in a requisition. You might have to call your local area. Typically, there is before primary care came in, it was all done through community supports, as far as I know. You may have to pay privately. There are some OTs that work for like private health clinics or for insurance companies that you could also contract, but you'd have to know about them. You'd have to be able to call them. And typically the rate is very, very high because they are, you're looking at like $100 or thereabouts like an hour. It might be cheaper, if someone does you a favor, but through the publicly funded system, I think you're looking at probably going to be community support services. So sometimes there's a central intake number, and that's like the same thing you would do to get access to like home supports and respite care and the type of stuff. You'd have to call that, basically leave your information and say what you're looking for, and then see where you are. I've heard of places where the wait list is like months and years, unfortunately. So what I am hoping to do, because I am trying to be preventative. We're trying to get that. I'm hoping some primary care teams have OTs, not all of them do. If you're in the St. John's area, there are, I believe, 3 or 4 family care teams between like West, Central, East. Um, you may be able to get a referral there if you're connected to one of them. If you're not connected, I would say your best place to go would be probably community sports services. And failing that, I would call the patient navigator and just say, I want to have an OT assessment for this Newfoundland Labrador home grant. How can I be put on a wait list, or who do I connect with in my area? Because depending on if you're in Labrador Grenfell zone, or if you're in Western or Central or Eastern urban or Eastern rural, they may have specific processes that might be a little bit different case by case. Did that answer the question, Courtney?
Yeah, definitely. I think that makes a lot of sense, and that's really helpful for people as kind of like a first step on in terms of how to get
Yeah.
there.
Yeah.
And for anyone who is considering this and isn't sure of who to call or anything, you can always give us a call as well at Seniors NL. We always try our best to send you to the right person to answer those questions as well. So that's just a friendly reminder there as well. But thank you, that's really helpful. So I'm having a look in the chat here now, and I don't see any other questions, but sometimes folks send me questions kind of individually if they're not comfortable asking in the chat or whatever it might be. So if
Yeah.
anybody wants to ask me a question or anything like that, I can always connect with Ted and get your questions answered. And I can also send any of those links that we weren't able to, maybe that video or anything like that, if anybody was interested. So what I'll do, if there's no other questions, or in the meantime, while we're just waiting to see if there's any last questions, I'm just going to pull up a few kind of final housekeeping slides, and then we will go ahead and finish up for the day. So just bear with me here one moment. Okay, so if you need a certificate of completion for today for professional development, just send me an email. So that's outreach@seniorsnl.ca, and I can get one of those set up for you. If you're interested in being a friend of Seniors NL as well, so Friends of Seniors NL is an intergenerational opportunity to engage people of any age in the well-being and independence of older adults. So anyone who's a friend of Seniors NL will be given business cards to distribute to those that they feel could benefit from Seniors NL services. And they'll also have the opportunity to attend presentations, workshops, and things like that in their community. And then just finally, this is our main info line, our main phone number, and our main website. And again, thank you so much, Ted, for being here today. And if there are any individual questions or anything like that, feel free to reach out to me and I can connect with Ted, and we can get those questions answered. But again, just thank you so much for coming in today and speaking with us. We really appreciate it. I think home modifications and occupational therapy is such an important facet of like family care teams and moving forward with aging well in place and aging at home. So we really appreciate you coming in and sharing today. So thank you, Ted.
No problem. Hopefully you guys see more of me.
Yes, hopefully. Yes,
Yeah.
thank you so much. So we'll finish there for today. A few thank yous there in the chat as well. And I hope everybody has a good day and a good afternoon. And again, any questions, feel free to reach out. But other than that, we'll finish for today.
All right. See you guys. Thank you very much.
Thank you, Ted. See you. Bye-bye.